Assalamu alaikum. Good afternoon, good morning to everybody who's joining us for today's webinar session for the Population Health and Wellbeing series. We are excited to have all of you here. I'm Dr. Sohela Chima, and I'm the Assistant Dean for the Institute for Population Health here at Weill Cornell Medicine-Qatar, and also an Associate Professor of Clinical Population Health Sciences. So as many of you may know, the objectives of this series are to discuss contemporary clinical topics relevant to healthcare, medicine, and population health, examine evidence-based practices which are germane to public health and patient care, and describe opportunities and challenges in the evolving face of healthcare and population health. Just some housekeeping. Your cameras and microphones have been turned off. You can use the question and answer feature to type any questions or comments, and questions will be addressed at the end of the session. I will be moderating the session. Also, you can actually post your comments and questions in the chat feature, and we should be able to view them. As a reminder, this is a CME activity, and this has been accredited both by ACCME and also by the Ministry of Public Health's Department of Healthcare Professions Accreditation section. Also, the post-activity evaluation will be available in the Cloud CME account by December the 4th. And healthcare practitioners which are licensed in Qatar, they will only receive their credits once the Qatar ID and MOPH license number has been provided. This is following the circular from the Accreditation Section, Department of Healthcare Professions, Ministry of Public Health. You will receive an email notification once the evaluation is available in your Cloud CME account, and certificates will be available for download once you complete the post-activity evaluation on the Cloud CME portal. So coming on to our speaker today, I'm really excited and honored to introduce our speaker for today's session, Dr. Scott Ratzan. So Dr. Ratzan is the founding editor-in-chief of the Journal of Health Communication, International Perspectives. He's co-chair of the Nature Medicine Commission on Quality Health Information for All. He has served on the board of Global Health for the National Academies of Science, Engineering, and Medicine, co-chair of the United Nations Secretary General's Every Woman, Every Child Innovation Working Group, and served on the Centers for Disease Control and Prevention Board of Scientific Counselors, Office of Infectious Disease. He has published extensively, including articles in the New England Journal of Medicine, Lancet, JAMA, Nature Medicine, Annals of Internal Medicine, and the National Academies of Medicine Perspectives. He has also written articles and offered expertise, including in the BMJ, Washington Post, Stat News, New York Times, and Financial Times, and also in broadcasting, including CNN, BBC, World News, Sky News, MSNBC, and others. Dr. Ratzan has an MD from the University of Southern California School of Medicine, an MPA from Harvard Kennedy School, and an MA in Communication from Emerson College. He is going to be talking to us today about health strategies and what are some of the strategies for impactful health communication. Dr. Ratzan, a very, very warm welcome to you, and thank you so much for doing the webinar today for us. Over to you.
Thank you very much, Dr. Chima, and very nice to be here virtually. I'm in my home office in Princeton, New Jersey, and it's just great to have so many of you on to hear about a topic that's been near and dear to my heart in my career, and I think is even more important than ever with what's been happening in terms of the importance of health communication. So thank you, Dr. Chima, and thank all of your folks there at Cornell Qatar for inviting me. And I will share my screen and we'll go through, I think what normal expectations are for about 40 minutes with our lecture here on strategies for impactful health communication. So with that, as mentioned, thank you for the long introduction. My work is all based on communication. I've been editing the journal, which is behind me, of health communication for 30 years. And clearly the field has evolved, and we are evolving with the field. I teach or lead a program in health communication for social change in New York, which is a fully online program that was a master's level. And I'm based in a school of public health and health policy, also with my medical appointments at Tufts Medical School and St. Andrews Medical School in Scotland. So, as all of these, there's a disclosure. I don't have any pharma or anything to disclose. I just gave a keynote on a similar topic for the American Medical Writers Association for an award there. A CME also for SUNY Albany, which is also online, which is on vaccine confidence and vaccine communication specifically. And I do some strategic work for these other groups that you see there. So as I move from my disclosure right to the learning objectives, our goal is to identify health communication strategies, recognize the meaning of of quality health information, which is the new big area, and develop ways to integrate effective communication to address information gaps, including misleading information in public health and patient care. So with that, just again, just a little bit further background, I just gave my principal positions, my recent positions, which Dr. Chima mentioned in my bio. I have done quite a bit on vaccine communication, beginning with my work when I was at USAID in Washington, writing a paper with John Clements called Misled and Confused, telling the public about MMR vaccine safety. And really, since that time, the whole vaccine area and the vaccine communication has been a big challenge for those of us in health communication. And I do my best. The last piece with a book that I edited on vaccine communication in a pandemic. But today, what we're going to talk about is more on just broad strategies for impactful health communication. I will end with some ideas also on vaccine communication and activities you can do both in public health practice and patient care practice. Now, in 1948, the World Health Organization was formed, and this was what, in the preamble, informed opinion and active cooperation on the part of the public are the utmost importance in the improvement of health of the people. This has been a goal, but nonetheless, as we know, it's not necessarily easy for this to happen. This has been a challenge in many ways, most particularly evident with the COVID pandemic. So where are we today? Well, we have a world where it's a sum of all fears. We might not have thought there'd have been a pandemic. And the little piece in the bottom, the people pushing against syringes and vaccination. We may have liked it better when we didn't have it really happening as we are today. So I mentioned the Journal of Health Communication. Just as background, it's published by Taylor and Francis. We've been around since 1995 for over 30 years, 2,700 peer-reviewed articles. What I think is key and what is not always evident in schools of medicine or schools of public health, population health, and so forth, is how important health communication is to be effective in our work in the healthcare field. And there's a strong evidence base for this. Not only we publish this, I used to carry around meta-analyses and background reports on effective communication and campaigns that have been published in Lancet and others. Overall, we know that communication is important, and we need to figure out a way to actually have this scientifically integrated in all the work that we do. So in year 2000, I was asked by the National Institutes for Health, National Library of Medicine, to give what they called the Leiter Lecture, which was a named lecture at NIH. And I chose to call it Quality Communication, the Path to Ideal Health. And really, at that time, it was clear to me that quality communication was important. And that's the work I was doing at USAID to define a strategy for work that the US government had funded at that time in up to 65 countries. And we had to make the case to fund this. And it was pretty clear, right? Communication was a catalyst for health improvement. We know more effective communication, more trustworthiness, trust and transparency gave people, whether they were considered consumers or whether they were considered patients, the idea to practice better health behaviors, whether it was prevention, to care, to cure. And we knew that partnerships amongst media, science, and institutions like NIH and the WHO were important, and we tried to foster those. We thought the internet could democratize knowledge. And just if you think back 25 years ago, only half of the world's population had ever made a phone call. That wasn't half the world's population ever had a phone, because now we know we have more phones than people, had ever made a phone call. So the world has changed just very quickly. And at that point, we thought the internet was all, well, was principally desktop. And now we see how it's in our lives, probably in many of your hands right now. Focus on building a health literate society. How do we build that? We thought that was a good idea. We wanted to support multi-sectoral partnerships for health, and we had the beginning of Gavi later. We had PEPFAR in the United States for HIV. There's a lot of things that happened. And we called for evidence-based, empathetic, and accessible communication. Fairly straightforward in terms of principles and ideas. The lecture is published also in the Journal of Health Communication, if you wanted to read it. There's a lot of different theoretical pieces in there, but it was a forward-thinking piece. And I'll come back to it at the end of, were we successful in all those and where are we today? And we knew what works and what to do. So as I jumped from the year 2000 and the year 2014, there was the Ebola outbreak in West Africa. And people in the United States were scared, for lack of a better term, that some people, including the CDC director at the time, said there could be 80 to 100,000 cases in the United States. Well, we had a cacophony of poor public health, where we had governors overriding some of the policies from Washington. We had people in Washington saying things different than we're saying in Atlanta, the CDC. So we published a very short article. To modify behavior requires direct, open, understandable, and timely information from a single authoritative source, as well as providing intermediaries with the tools they need to reinforce the message. Fairly simple that if you're designing government communication, you can't do it in a vacuum. You need to have those intermediaries. Many of you on the CME here now, whether it's health professionals, policymakers, leaders of schools, clergy, what have you, those intermediaries need to have the tools, and the medical associations and others often were getting the information at the same time as the public. So fast forward to 2014, remember the cartoon of the sum of all fears? Well, we saw COVID breaking out, and as Dr. Chima mentioned at the outset, I was on the board of global health for the national academies at the time. We met in January, end of January. A couple of us saw what was happening with COVID. So I wrote this paper along with Larry Gostin, who's at Georgetown, and others. And I think what's clear here is we said the same thing. An urgent call for coordinated, trusted sources to tell everyone what they need to know and do. That's the title of this. We published this before it was even termed a pandemic at that point by the WHO or other governments. And number 5 means it was the 5th top paper of the year, so it was read. But we do know today that it wasn't followed. We did not have a coordinated, trusted source, and it was a test of the health policy's credibility around the world, whether we wanted to say this was what we were calling for in the United States. The WHO, unfortunately, didn't also have the trusted source that they needed. And the threat means that we needed to do what we said in 2000, get government, media, technology platforms, and the private sector to all step up together. So the world has evolved, but maybe our institutions have not. And it's not just me saying that. You can look at the report led by Helen Clark for the WHO that she said, they said actually, that the institutions are not prepared for the pandemic and weren't, and we need to reform them. At the same time, Neil Ferguson, a historian who is based out at Stanford now, and Emery Slaughter, former dean of the Woodrow Wilson School of here in Princeton, wrote 2 different books, and one reminded on the left, Neil Ferguson, the square and the tower. If anybody's been to Siena, that's when the old days, the centuries back, they would go to the top of the tower, they'd make whatever proclamation, and people in the square in each of those 9 areas would follow, and they'd go back to their districts or their areas and have sort of a hierarchical structured approach. And people were motivated differently in those days. Much more self-interest, and decisions were made, shall we say, that were based always on well, not always, but principally on evidence and on a hierarchical decision-making process. that exists in some countries more than others. On the other hand, though, the chessboard and the web reminds that the world has changed. We no longer have somebody can go to the top in Siena from Geneva, from London, from Doha, from Washington, wherever, and just make this all happen in a given country or a given place because the network is so fast and people are motivated very differently. Engagement is the first thing. Does this connect with me? What are the norms in society or the norms of even the medium of how people communicate on a Twitter or a YouTube or a TikTok are very different than how they communicate in the days past when in the square in the tower. But more importantly, we know that emotional elements are what drive people to make decisions. So we have a field of health communication. The field of communication began in the United States in 1947 with the first doctoral program. Since that time, there's about 47 programs in health communication. If you believe some of the search engines, there's over a couple of hundred around the world. Some are single courses, some are broad-based. But the key here goes back to the Aristotelian rhetoric of where I was trained in my undergraduate degree, uh, both before medicine. I studied political rhetoric, and this is basically just taking Aristotelian ideas. If you studied persuasion there, where he talks about ethos, pathos, and logos. Ethos on the left, well, we have source integrity of the person who's speaking that's based on credibility that has science and ethical precepts. All of us hopefully are in that spot and work to do our best to increase that. But at the same time, it's ethos, pathos in the middle, understanding people where they are with listening and empathy. And then finally, logos, using logical and evidence-based approaches to how we reach people that are tailored to perhaps the time of diagnosis, the time they are in their treatment, and segmenting also amongst populations, whether they're young, whether they're old, whether they're overweight, whether they're diabetic or what have you. So these are just basic strategies that we have. And we have a field that's developed, which is why it's really great to be here with all of you today. I think you're all in Doha or Qatar, but wherever you may be, this field is a broad base with communication science, social science, physical science, and it influences the fields that many of us practice in and where we have professional degrees or need ongoing continuing education. As you see, medicine, nursing, pharmacy, dentistry, health administration, public health, epidemiology, health informatics, and the link with public policy. Now, health communication also, if we take the field, I have this as the fundamental of the program that we lead in New York. Health communication as the science and art of using communication to advance the health and well-being of people and populations. In short, we have to get the right information to the right people at the right time and the right place for the intended outcome. And an entire master's program or 8 courses could be based around these. Community engagement and partnerships is probably amongst the most important and fundamental. Do we engage people in different communities in ways that they can help make the appropriate health decision for themselves and the community, which includes access to health, access to services, access to information. And then the other areas are communication strategies that we may have more in schools of population health or other areas, such as mass communication and social marketing. Do we still use television or radio? Radio is still very effective in many populations. And social marketing is, again, using the segmentation strategies to reach people on areas that are good for, just like we could market soap for hand washing, we can also market other products and ideas for, shall we say, better nutrition or preventive behaviors such as exercise and so forth. Public relations, public affairs, and media, very important that we get health in all policies, but we also get health with what people talk about. And that's what public relations is. Not getting people necessarily what to think, but what to think about. And if we get them to think about their health as a common currency and the most important thing that they do each day, or at least an important thing they do each day, perhaps they can adopt preventative behaviors or have compliance or accordance with many of the prescriptions or suggestions or ideas that you share with your patients and your populations. Multi-sector engagement. As mentioned at the beginning, I've been in different sectors. I've been in the government sector, in the private sector, and now principally in academics. when I left the private sector, I went back to Harvard Kennedy School as a senior fellow in the Center for Business and Government, the Mossavar Rahamni Center for Business and Government. And in that center, I advocated for multi-sector engagement for sustainable health. And if you look on the Harvard Kennedy website, we published a whole paper on what that might be for the Sustainable Development Goals with principles for multi-sector engagement for sustainable health. I teach a whole semester-long course on that. But the important piece is if we want to have these long-term uh, activities that are effective, such as Gavi, such as the Global Fund, we need all sectors involved. And that includes, again, the professional sector, which often is just brought in for expertise, but I think the professional sector ought to be brought in for both design, development, evaluation, and for impact. And that's why the multi-sector engagement is near and dear to my heart and something that I think we all need to embrace. Advocacy, policy making, and strategic diplomacy. Part of the idea is if we want to have this that's sustainable, we need to have policies in place. And I say this could be anti-smoking policies or anti-tobacco. Then we need to have policies. I call them little p policies. It could be a policy at a workplace or workplace at a school. Big P policies, such as taxation of unhealthful products or things of that nature that could be at a national level or at a global level, such as the pandemic treaty, which is what we need strategic diplomacy of how we would share pathogens or share vaccines, or even I think as Dr. Tedros said yesterday, even think about the tiered pricing and the other parts that are engaged to get people access around the world to the medicines that have been developed to help people live longer, healthier, and better quality lives. And all of this keeps leading up to social norms and sustainability. When I was born, I think the social norm, well, it was okay to smoke. You could smoke on airplanes. You could smoke almost anywhere. In the United States, over 20, well, at one point over a third of people were smoking. Now the social norm has gone much lower. Similarly, the idea of wearing seatbelts. It wasn't just putting the seatbelt in the car, people didn't adopt it. You also needed to have the policies in place to wear a seatbelt, the regulations in place for the bells to ring in the car if you didn't have it on. And you need to then also even have enforcement mechanisms. And now it's a social norm in most places, even when people go in the back of a taxi or wherever it may be, to wear a seatbelt. And then finally, health literacy training and education. All of this is long term. We can't do this overnight. We need to embrace this in schools. The health literacy training in Finland is one of the best examples. They did best during COVID with getting their population vaccinated, and also some of the preventative health behaviors that they've adopted. The definition of health literacy that's been adopted in the United States, I worked on with Dr. Ruth Parker at Emory School of Medicine. We have tried our best to get that integrated amongst what we call attributes of health literate organizations. So every hospital, healthcare facility, workplace would actually have some of these in mind. But we also need to have this in schools and universities and other places. So this is the fundamentals of what health communication is. And hopefully today we can think a little bit more about it. But this is what's going on today. We have the media used to decide what truth was, the independent arbiter, which could have been a policymaker, a regulator, or the politician would decide. But this time I asked AI, ChatGPT, I said, I want to update. You guys, so to speak, are making a decision. And I actually put this into ChatGPT and it added AI, the algorithm. And as you can see, it spelled algorithm wrong, but it shows you that ChatGPT can actually do stuff, but it's not always accurate. But they're certainly deciding what information is available today. And I think we need to communicate not only directly to the media, arbiters, and politicians and our public, but also via these algorithms. And we know this is the case from information being identified as determinative health in an article in Nature Medicine in 2024, written by Garth Graham and other of his colleagues from Google YouTube. And at that point, they were reminding the importance of information as a determinant. And we certainly embrace that as a challenge and something that we need to do. So as mentioned in the intro, a year later after that article, I was asked to help develop a commission for Nature Medicine on quality health information for all. And we announced this, and this was published in January 25. We had our first meeting at the World Health Summit in Berlin. I'll show a slide on that in a moment. And we have some very specific goals that we think is important that people will publish and hopefully can be adopted. One, quantify the impact of gaps in access to quality health information on individual health and national economic growth. We know investing in health has dividends, not only economic, but health dividends. We want to help provide broader access to accurate, reliable health communication now in the digital era, improve public health by advancing health literacy and information equity. And then finally, which is why it's great to also be here today, affirm the importance of health communication as a distinct discipline to advance health. While it's great to do this 1 hour seminar, it's hard to do justice to a discipline that, as you saw, had that whole stepping stone of activities and different evidence base today. So we had our first meeting in Berlin, and the challenge, of course, was what do we do with what is quality health information is? There's no clear definition. So this is the first piece we came up with. Quality health information is scientifically sound, accessible, clear, understandable, and essential for appropriate decision making that improves health. So we have 5 working groups. You can see some of them on the screen behind me. One on understanding the cultural context, which is led by one of the co-chairs with me, Heidi Larson, and other parts that we're addressing. But we also say appropriate decision making because we need to give people the information that will help them make decisions that are also culturally specific, and also to make sure that there's access to the medicines or the diagnostics or the prescriptions that we offer. So going back to where we were in 2020, I mentioned the vision where I had for at the NIH, data growth, ethical global cooperation, health as a shared social responsibility, health literate society, and partnerships. And we did have a lot of those up until the last couple years. We started to have, for lack of a better term, a wrecking ball or a big paradigm shift of what's happening at the global institutions, with the United States pulling out some funding of the World Health Organization, with the stoppage, shall we say, of both USAID global health activities and PEPFAR and others. But we also have this new algorithm that's coming in here, right? So things are AI driven. All of a sudden, we have strong anti-vaccine communities. We have others that are speaking about medical freedom, that we have the freedom to make choices ourselves and not necessarily with a health professional. So the world is changing, that we have this AI-driven social amplification. We have politicized movements, again, around areas challenging our institutional authority and science and evidence and what we all had both studied and belief for centuries now, of art, nature, of scientific base for what we do. Health and policy decisions are challenged by ideology, distrust, and the declining institutional capacity. The social media platforms are changing with new forms of literacy. And finally, a big challenge we have is how power is consolidating on who is deciding what information we get, and the new gatekeepers of information are no longer amongst us. This is from a short article I wrote that was published during the World Health Summit, and also an excellent article from the Carnegie Endowment on expertise to matter. Nonpartisan institutions need new communication strategies, and I do believe that that is the case of why we need quality communication. But what does this hold for all of you in how you communicate for public health and patient care? It means we have to do these things, and these things are quite important. These are just 10 ideas that are all evidence-based, and some you might say, I do already, but we need to reinforce them. Listen with empathy to understand what people value and fear. That's whether we're doing a public health campaign, whether we're talking to an individual patient, whether we're talking to a family member, friend, colleague, boss, whoever it might be. We need to understand that they value and fear. Communicate consistently with clarity and conviction, not jargon. I probably have used some jargon already. This is a difficult piece, particularly in our field, where we're a jargon-laden field, to just be frank. We need to act quickly and creatively and adapt messages for real-world impact. Things change. If there's an outbreak of measles, it's going to be a different term when there's an outbreak, when there's an epidemic, when there's a pandemic, when it's an infinitesimal risk, a negligible risk, a real risk. All these pieces we have to adapt for impact at the right time. Model trust and transparency. that we want to be the trusted source and we want to be transparent in how we got to decisions. And hence we need to both publish, in many cases, not only our research, but how we end up at decisions. Develop, demand, and deliver health information that's scientifically sound, accurate, understandable, and engaging. That's the idea of quality health information. That also means sometimes we have to test our messages to make sure that we're delivering them with the intended effect. We need to recognize the value of quality health information and galvanize multi-sectoral responses at all levels of the life course and patient journey. I've worked a lot of times in big groups, and if I ask everybody, are you a patient in an audience? Everybody will not raise their hand. People only feel that they're patients at a time when they're often sick. They don't think about it in their life course. We have to think about it that way of when we're actually communicating. We have to think about health communication as a shared responsibility. We can't just end our work on a paper and then say, oh, bring the communication people in, write a media release and get the information out. It's for everyone to be engaged. And then how do we leverage media and new technologies for a credible, evidence-based, trustworthy source with coordinated communication efforts with ethos and transparency. And frankly, Cornell, while it's where I go to medical care here in New York, it's a brand, it's a trustworthy source. How do we continue to advance what we do in that regard as well? So here's just a couple of examples for those of you who are in clinical care that improving health communication, we have approaches with active listening. And these slides will be available, so I don't want to read all of them in the interest of time, but to remind, there's this old traditional approach. I could have wore a white coat and thought I had the white coat ethos. I walk in, I'm the expert, I'm going to persuade you. No. Nowadays, physicians, pharmacists, nurses, others, we're the guide. We need to try to engage. We need to help people understand. And that often does not only happen in the patient examination room or consultation room, it also happens with the active approach as soon as somebody walks in to that healthcare facility. I assume that people don't want the service or have the wrong information if they don't want to take a vaccine. We have to try to listen again and think that everybody cares about their health and why they're choosing or why they may not be interested in a given medicine or vaccination or whatever it might be. And then also, we used to think, oh, we had whatever we said would follow, and if not, so be it. Well, now we need to respect people a little bit more, share their concerns. So here's the example with vaccination. Again, with Ruth Parker and I, we wrote the vaccine literacy, helping everybody to decide and accept vaccination. I wrote a short article in Harvard Business Review in 2011. If you do a quick search, it's available on what vaccine literacy is and why we need a new approach to vaccination. But essentially, we have to remind people it's when they have the skills and ability that align with the content, processes, and systems needed to access and get vaccinated. Knowing how and why vaccines work, the diseases they prevent, and their value to yourself and society. We don't need to explain the entire mRNA process and how vaccines were designed, but we do have to remind people that vaccines work to prevent disease, not necessarily eliminate disease in some ways. And also, even there are some differences, obviously, with live attenuated and the new particle vaccines or mRNA vaccines that are often called. We also know that these are not one-offs. People build vaccine confidence over time, so they need multiple conversations, and it might mean they also need, other prompts, whether it's in the waiting room, a sheet of paper, a poster, other areas that they've heard. So we know this takes time, and hence it's not only in the office or healthcare facility. So what are some other potential scenarios we have with vaccine literacy and patient care? Here's one in terms of another example on somebody wanting to get their annual flu shot. The first is ask about their concerns. You're here to get your physical. You're here for whether it's another ailment. We can still, in primary care, ask them, are they interested in getting their flu shot at the appropriate time? And then we reflect back on a script. If they say, no, I'm not interested, well, you're not sure, what are your concerns? Continue on. Oh, okay. Well, if it's a pregnant case, okay, you deal with the pregnancy issue. So I might say, I'm pregnant and can't risk harming my baby. I've also heard new studies that say vaccines may be linked to autism. And then obviously you address their concerns and meet them where they are. You're worried the vaccine will be bad for your baby's health. That's an understandable, scary thought. Your baby's your priority. You don't want to risk their health. And then continue on, reflect, affirm, provide information. Can I provide additional information to you? Um, and if the answer is yes, how do they get that information? Where do they get that? And you can explain with the information that many studies, in this case on pregnancy, people have been vaccinated. Vaccines are important for you and the baby's health. They've been found to be safe. So you talk about safe, effectiveness, and easy to use, and the ability to get the action today. Do you think you'd be willing to get the vaccine? And then finally, connect people. All right, they're willing to get the vaccine. Affirm they've made a great decision. Would you like to schedule an appointment or get it now if it's possible? And if not, okay, so you're not interested. Thank you for taking the time. Here's more information. Go back and learn some more and hopefully come back with other questions. The last piece is if you're interested in community health communication practices, we developed a checklist, and this checklist we published with the Health Equity Community Collaborative. It's on uh, it's on another continuing education program that I did, but it's a little checklist rather than go through that. Just to say, if you're in these different areas, there's different checklists. I'm a big believer in checklists. Atul Gawande wrote the book, The Checklist Manifesto, who is he was a public health physician at one point at Harvard School of Public Health, and talked quite a bit about the success we've had with the safe surgery checklist, the success we've had with venous catheters, and the success we've had with checklists in terms of other fields, whether it's engineering, air flights, and so forth. I have done my best to publish probably 6 different checklists in different areas. This is one for community health communication practices. Many of you might also have checklists in your institutions and your fields of study and your hopefully daily activities that you think through not only in a deductive and inductive approach as appropriate, but also amongst the areas we spoke about today. So with that, I'm going to end with our opportunity. I think we all have an opportunity to advance quality health information so we can improve health equity, build trust, and advance public health for people and communities globally. My theme of my Harvard fellowship was Sisyphus, getting past Sisyphus. Sisyphus on the left was condemned to immortality, and he thought it would be a good thing, but condemned to immortality was to push the rock up the hill only to get it to the top, and it kept coming down. And that's what Sisyphus had to do for his entire life. But when Camus, centuries, 2,000 years later, wrote about the myth of Sisyphus, reminded that Sisyphus was actually happy doing what he was doing. But it also has this reminder of everything that we do. There are a lot of opportunities, and we have to think broadly and have to work toward quality. There's no longer a single idea explaining everything, but an infinite number of essences giving a meaning to an infinite number of objects. The world comes to a stop, but also lights up. I say this that we're in a challenging time. Those of you know that medicine has changed, or health has changed, or nursing has changed with technology, with what I talked about earlier of the multi-sectoral and other institutions, the funding challenges we face. So we need all of us to do this together and think about the infinite number of essences and follow our hearts and science for providing better patient care, better population health outcomes, and making the world a better place. So I thank all of you for that opportunity. Please feel free to reach me on LinkedIn. This is my email at my institution. My LinkedIn, I think, has similar emails and other information about me. So I'm happy to answer some questions and move along here. So I'll end
Yes.
with the slides and back to you, Dr. Chima.
Thank you so much, Dr. Ratzan. That was like a wonderful session, giving us a very good overview about health, how to make strategies, impactful for health communication. So we have a few questions, which have come into us. So I will just start. So what are your thoughts about, how the rise of like social media, AI, the ChatGPT landscape, how has that changed the landscape of health communication? And what strategies, could be more effective now since we are in this space?
Sure. Well, first of all, I hope I emphasize that enough. Yes, the landscape has changed, and
Yes.
hence even in our Nature Medicine Commission on Quality Health Information for All, reinventing health communication in the digital era. So we need to do that with a quality mindset. So it has changed immensely in that people are getting their information principally from now social media we're learning, and this is not, I shouldn't say everybody is. We did a 30 country survey that we hope to publish soon, where people are getting their information. And yes, we're finding they're principally getting it from social media, but they also are principally getting it, at least across the world in this survey. This was fielded in August. They want it with social media, but they want it with words and visuals. They don't want it with words and videos. So we can't think that TikTok videos are the answer or a long video is the answer. We need to meet people where they are. They want short, succinct, and areas that they might be able to click on and go deeper. Now, what I do think is interesting and what I tried to highlight in that 2020 to 2025 slide, since it's changed so much, that we have to communicate with social media in mind. So how do we tailor our messages where the algorithm will pick it up? Just like if you're writing an article for publication, you want to put keywords in there so researchers can find it on a quick search.
Mhm.
We also need to think about that if the public is getting that in social media. And I think the other piece is don't think that just social media is you putting your name and your brand or your information just on an X platform or Instagram or what have you. I do believe the Weill Cornell Medicine, whether it's the Cutter Center or New York or the global pieces where your institutions are in partnership, you can create your own credible sources and amplify where people are getting information from you. I say that you because oftentimes we're now finding the professional groups and the institutions are more important than even the governments, as people aren't as trusting of the CDC in the United States as they used to be, for example, or not as trusting as we found in our global survey of the WHO and the international institutions. So we have to think specifically of finding the right media that's meeting people in the right place at the right time. And that means understanding social media, but not abandoning do not abandon the old media, if we call it that, or the legacy media, because that will be around. And every time we get a new media, we think, oh, the last one will disappear. We haven't got rid of radio. We haven't got rid of uh, newspapers yet. Some of them are dwindling for sure. But we need to be able to think about all of the different media and have a media strategy that goes from social to traditional.
Great. Thank you for that. We have a question about how effective do you think is creating mobile apps on health communication or AI health coaches? What are your thoughts about that?
Sure. So I didn't talk about this, but I helped develop the first mobile app in the United States called Text for Baby. That I
Mhm.
that was we published the article if you want to read about it in the American Journal of Public Health. But essentially, it was an app that women could opt into and during pregnancy get tailored information day by day of where they were in the 9 months with not only what to expect from their baby, but also or their infant or child's whatever you want to term during pregnancy. Uh, so as the fetus developed, we would also remind, oh, now's the time to make sure that your hepatitis shot would be up to date, or now's the time on other areas, including folate and so forth. I think tailored messages that are mobile that people hop into are excellent to use. Now we have the link with wearables.
Mhm.
So, if people want to actually have that engagement, we have a lot of those obviously with diabetes management and so forth. Um,
Right.
but I also feel we did one study we called it the Mobile Alliance for Maternal Action, which was another mobile application that we used also during pregnancy and the first years of birth a number of countries, and
Mhm.
we put it in. It was a listening app, so the woman in this case would most likely be able to hear in their own dialect, in their own local language of what needed to be done with a health perspective, they're taking it down to their health literacy level. So I'm a strong believer in using mobile apps. In terms of AI and chatbots, actually, we're writing an article amongst some of our journal editors that we want to make sure that this is done in an evidence-based approach and with an ethical framework. There already have been some unfortunate breaches in the mental health side, so it needs appropriate guardrails.
Right.
Um, I say breaches if people have read about leading adolescents potentially to poor decisions or in an unfortunate case of a suicide or so forth. So
Mhm.
we need them, we need to embrace them, and medical professionals and health professionals need to be engaged with their design and development. We
Yeah,
cannot let the tech folks do it alone.
absolutely.
Mhm.
Thank you for that. So, Dr. Rajan, you focus on the importance of quality information. So, how can we combat, misinformation, this disinformation, and how can communicators, build and maintain the trust with the public?
This is an excellent point, and it's something that I we all struggle with. In
Mhm.
fact, one of the courses I teach is advancing quality health information, and one of the readings is the confronting health misinformation, which is the U.S.
Right,
Surgeon General's report. So there's
right,
lots of ideas of what can be done, but actually doing it is a different piece. So I'm not a believer that we use these medical terms in the communication field. We need an inoculation theory. Well, we
right,
don't need to really, we know that if you give people the right information in an ongoing way from a trustworthy source, that they will have more of that believability, and it's harder to wrestle the truths that are so-called self-evidence away from people. So we have to work harder as health professionals to build quality information in the trusted source and get people to know where to go to get the information. That
right,
means if there is misinformation or poor information or misleading information or information that can cause harm, we do need to confront that. And we do need to uh, state, no, these are the facts. And we need to figure out ways to meet people where they are and how that information uh, overload that they might be getting that's wrong
mhm,
has a different effect from those of us in medicine and health professional fields. It's much easier said than done,
right,
and hence that's why we have a course in that, and hence also that's why that step ladder of multi-sector engagement, health literacy, digital literacy, and I think it would be terrific if there was the interest of deep health literacy, if I can call it that, or digital literacy there in
mhm,
Qatar, or any country. I've only been to Doha on one occasion, actually during a World Economic Forum meeting, to talk about the importance of focusing on health communication years ago, pre-pandemic, and still there's not the level of investment that we need at any governmental level, shall I say. And I can't say that the World Economic Forum folks also had embraced it in the way that's necessary. So now more than ever, people who are listening, if you're in leadership positions, how do we invest in it? I work with all sorts of groups. I work with companies on strategies. During COVID, we still have on the website of the U.S. Council for International Business that I disclosed learning modules on
mhm.
vaccination in the workplace. And
Right.
it wasn't like combating misinformation. It was just getting people flu vaccine or COVID vaccine or washing their hands, all those pieces together. So we have to think about creative ways to do this.
Right. Thank you, Dr. Ratzan. So, Dr. Ratzan, you alluded to, getting the right message in the right time, right manner, right time, to the right people and the place for the intended outcome. And you also allude to health literacy, which is very important. So, what strategies, do you recommend for tailoring messages to diverse audiences with varying, levels of health literacy? Can you embellish a little bit on that?
Sure. So health literacy is giving people the information to obtain, process, understand, and make appropriate health decisions. So
Hmm.
the appropriate health decisions is what's appropriate to them in their context.
Right.
And what oftentimes happens with health literacy is we take it to the lowest common denominator, but it also links with how we segment where they are. So in the workplace, as I
Hmm.
just mentioned, we might have different ideas for what is health literacy of not only understanding your insurance plan or policy or what the government's offering, to also understanding your role as an active citizen or active member of whether it's a health plan, a workplace policy, a union, or whatever it might be. So we need to tailor these at different times and different places. many people in health literacy say, oh, let's just make clear communication, take out the jargon and give them the information. But I can point to plenty of books and stuff behind me where the information's there, but it doesn't translate research into practice. So my suggestion is to really segment and tailor health literacy. So there's health literacy for the schools, there's health literacy for the workplace, there's health
Mhm.
literacy in a physician's office, pharmacy, retail, wherever it might be. And we realize that we have opportunities to communicate with people in language that they understand and in medium that they understand. So it may not be a language, it may be a visual picture that shows everybody that looks like them in their community getting a vaccine, or everybody that looks like them
Mhm.
uh, on a television show, or embodied in a discussion, whether it's news or entertainment, eating properly, fresh fruits and vegetables, exercising, uh, not smoking, lowering their intake of sugar, ultra processed foods, and all those pieces, addressing, interests with alcohol and so forth. Um, all of those could be social norms that are brought to a level of health literacy that what people can understand. And that's why sometimes it needs people trained in communication, not just trained in medicine or
Right.
healthcare.
Great. Maybe we can just take this a little bit further for one more question. So, how can we, communicators ensure cultural sensitivity and inclusivity in global health messaging? What are your thoughts on that?
Well, the term that we used to use, and the cultural sensitivity was key of what we tried to design when USAID. We had a whole
Mhm.
global health communication strategy. Also, when I worked in the U.S., the term what we use is formative research.
Okay.
And formative research. For I can say that three times before you do anything. Inform, bring in the people that you hope to communicate with,
Okay.
and not communicate to. So bring in the community and listen to them and test your messages. Formative research means to inform the process with sometimes focus groups. Um, so bring in, 8 to 12 people in the audience that may be able to understand, have a good moderated, piece of what information you want to bring forward to understand their cultural thinking, understand where some of those barriers might be. And it could be so simple as the person that you put on looks like me and, doesn't look like you. In all respect, Dr. Chima, they will listen to you more in a different context than they'll listen to someone like me. Or neither of us. They might need to have, some of their a religious leader, or
Mhm.
someone who in their family or with a certain last name. So we
Mhm.
need to understand that culture, and the only way to understand it is to bring people together and do this formative research. So it could be somewhat quantitative
Mhm.
to measure it, but qualitative is key with focus groups, in-depth interviews. Oftentimes we call these mixed methods, so you do
Right.
both, and so forth. So I can't implore any more than that. And we integrated that in what we did with all the USAID work, which is generally through Johns Hopkins, around the world, partnering with local institutions, and even work when, like for example, I lead a CDC coordinating center on advancing research and immunization services network, 8 universities. We
Mhm.
also are in the process with all of them of understanding the culture of different parts in the United States and the subcultures. I mean, in New York City, where we are, we put stuff out in 13 different languages, the city of health and hospitals. And that's not even all, of course. So, and need to look at the subpopulations amongst those and the dialects, as I mentioned earlier. So it is more complex, but super important. I want to thank whoever asked that question, and all of you to go take the take home message. Always think about the people you're trying to reach, understand their culture, and engage with the ethical, quality health communication.
Mhm. Great, thank you. Just the last couple of questions, Dr. Ratzan now. So, of course, we are going through communication challenges. So, how do we prepare, for the next wave, or even just, trying to combat these? I know you've mentioned, a lot of what we can do, but maybe, just giving some key pointers and what we should keep in mind, in trying to manage these communication
Sure.
challenges we are seeing in public health.
Well, I would like to have some demonstration projects. Our commission
Mhm.
has some preliminary, what we call health information quality indicators.
Okay.
And we're modeling the approaches from OECD, who's on there, and WHO, who's on our commission, and also the national academies when they used to do these indicators. So we would like to have some demonstration projects with that. Uh,
Mhm.
we have a couple already in the works with Austria, Switzerland, Germany, Canada. We'd welcome anything with anybody there in Qatar, of course, or any of the place people where you're listening. But to take get ahead of the game. So these are the information
Yeah.
quality indicators, and are we doing that, whether it's at Well Cornell Medicine, whether it's a government, whether it's, a local partner, and not with naming and shaming, but rising the coal quality level. So if we know we need to have, competence and transparency and trustworthiness, and then have pieces there. So that's how to get ahead. I think identify one, what the quality indicators are, and develop that with quality healthcare. Two, perhaps have a demonstration project that's in a particular chronic disease area, since there's a lot more depth in research, whether it's on, diabetes, metabolic disease, hypertension, where you can actually bring everything across the whole patient journey and continuum.
Mhm.
Um, and then three, try a multi-sector approach. See if there's something that you can do with the workplace strategy, and see if you can drive down poor health behaviors, and drive up, good health behaviors. So whether it's, get your vaccination rate to whatever level, get your, smoking, physical activity, nutrition, if you can get people to do some self-report. So there's all ways to do it.
Yeah.
And that would be my suggestion.
Great, thank you. The last question for today. So what emerging trends or technologies do you see shaping the future of impactful communication? What are your thoughts about that?
Well, the interesting thing is when we did the text for baby that I mentioned, I would say that we have health in everybody's hand, and we have
Right,
all the positive things. We know that this has a hazard.
right.
People will do it when they're driving, right? And all of a sudden we have more accidents from distracted driving. Uh,
Mm.
we have to think in creative ways. If the phone or well, the phone will change into it's already changed more a data device than
Mhm.
necessarily just a telephonic. So, I think we need to think forward how we can use the technology appropriate where people are, the interactivity of it. Maybe I should put QR codes on some of my slides. If you want more info, it's easier to get. We got to make it easy. We got to
Right.
make our health more fun and popularize it. That's not easy to do. So I think that we need to learn from social media where they've been able to do that with other, gamification and so forth. But we also need to again put the guardrails in place. So I do see it going more in a new network, and new ways of reaching people, and with the chat GPT and AI helping us make decisions, we're going to have more of that creeping into the healthcare facility at all levels. Patients won't just have their Google search, they'll have chat GPT that will have the answer search. And we're going from search engines to answer engines, and that's a big challenge for us. We've got to really think about how we help people get the answer that's proper, correct, culturally sensitive, health literate, and of high quality. So I'm about, if anybody wants to join our quality movement, that's where I want to have a quality health information movement. And that's where I see the positive stuff going, but the negative headwinds are difficult. And we need everybody together on this. And I know I want to thank all of you who've joined today. And hopefully we could, think a little bit more going forward to work together on this.
Yes, absolutely. And thank you so much. I think you're absolutely right about all those things that you mentioned. And we would like to thank you for doing today's session. I know you're very busy, but thank you so much for taking the time out. And let's watch how the communication landscape changes. It's just evolving very, very rapidly. I think we will all see how it goes. And we would like to thank all our participants who've joined us from Qatar and maybe from different parts of the world. We have about 350 people who've joined us. So thank you very much to everybody.